About nystagmus and assessment of the vestibular apparatus, we could do clinical exam or the lab examination. Let's talk about the clinical examination. First, we have to talk about spontaneous nystagmus. So, spontaneous nystagmus is a nystagmus which is not induced by what do you call greater than 30 degrees. What I meant to say is that, see, what is spontaneous nystagmus? It is a nystagmus which has two components, the fast component and the slow component, and it is a condition in which there is rhythmic oscillatory involuntary movement of the eyes. Rhythmic oscillatory involuntary movement of the eyes. Now this kind of nystagmus could be three types. It could be rotatory, it could be horizontal, it could be vertical, and importantly the fast component is the one which usually defines the direction of the nystagmus. That is very important. So that is vestibular nystagmus. Having said that, vestibular neuritis, how do you assess it? Is like you take an object and finger, probably keep it in the visual axis, and then move that finger up, down, right, left, whatever it is, but whatever it is less than 30 degrees, because after 30 degrees it will go to something called as gaze induced nystagmus. And always remember, if there is spontaneous nystagmus, understand that it is always a organic type of lesion. And then you have to talk about right, see, this type of vestibular nystagmus which we are usually talking about is of two types. One is the peripheral type and the central type. Peripheral type is usually because the eighth nerve getting involved, or the inner ear or the vestibular apparatus getting involved, whereas the talking about the central one, which is due to the cerebellum or the vestibular nuclei or the brain being involved. And how do you usually suppress the what do you call first let's talk about, so having said that, understand this, that these two type of labyrinth nystagmus can also be because of two types of labyrinthitis. Let's say there is a serous type of labyrinthitis or there is purulent type of labyrinthitis. In serous type, well, in this kind of condition, the nystagmus happens to the same side, whereas purulent, or there is trauma, or there is any paratic type of lesion, the nystagmus can happen to the healthy side also. But always remember, to kind of decrease the nystagmus of the peripheral origin, you can do optic fixation, but you can also give something called as Frenzel glasses of +2 anti-diopter glasses, which abolish the optic fixation. But remember this very important thing, the nystagmus of the central origin cannot usually be suppressed by optic fixation, but you have four types of nystagmus which we have to talk about here. One is the vertical upbeat, vertical downbeat, torsional nystagmus, pendular nystagmus. Torsional nystagmus is something which is seen in syringomelia, like wherever there is lesions in the brainstem or the vestibular nucleus. Vertical downbeat matlab craniocervical region. So here it is seen in Arnold-Chiari syndrome, it is seen in degenerative conditions of the cerebellum. Then you have the upbeat. Upbeat is something which is seen in the medulla or the midbrain, like up pons, up pons to the midbrain and medulla. Lastly, I have the pendular type. Pendular type is something which would be congenital or acquired. It is sometimes disconjunctive, which means like one eye can go up, one eye can come down, right? And this is seen in MS, that is multiple sclerosis. Talking about fistula test, see, fistula test is based on the principle that pressure differences usually travel from the external ear to the internal ear. That is important. Now, what you do is you take a Siegel speculum and do intermittent pressure upon to the tragus. What happens is usually it is negative. That is the middle ear, and then the protection does not let the pressure pass, but let's say if there is a condition of surgery which you have had recently, like a horizontal subcircular canal surgery or a cholesteatoma surgery, there will be some opening which will usually allow this pressure to pass by and it becomes positive. Or let's say the oval window has any fistula and post epidectomy kind of fistula or rupture of the round window, that will basically lead to the pressure going in. But one thing which you need to understand is that the positive fistula test implies that the labyrinth is still functioning. If it is not functioning, there will be no the person will not have any vertigo or nystagmus which will happen, right? This pressure changes will cause nystagmus. Now, so it is having it. If it is a dead labyrinth, then it does not happen. That is one thing. Now, a false negative is usually possible. False negative usually happens if the cholesteatoma is covering the fistula. A false positive also happens. This is a very beautiful case. So let's say they have Meniere's disease, where they'll have fibrous bands which connecting the macula with the foot plate of the stapes. What happens is, along with that, let's say they have something like congenital syphilis. So what ultimately happens is the foot plate is somehow dilated, or there will be this dilation, because of which the person will have nystagmus, or there will be hypermobile, what do you call, hypermobility of the stapes foot plate. So this leads to false positive fistula test. This is usually seen in 25% cases of the congenital syphilis, and yeah, that is important. And yeah, that is fistula test. Whenever we talk about the Romberg test, we have to remember that first the eyes are open, then you ask him to close the eyes. So if the person is having a peripheral type of lesion, then he'll sway to that side. But if it's central type of vestibular lesion, then he'll be unstable. It might sway to the right or left. See, that is one test. Even if you find that negative, you do something called a sharpened Romberg's test. So in this condition, the patient is made to make his heel be in front of the other front of the toes, like so one foot will be there in front of that toes. You ask them to put the heel, and ask him to get the arms closer to the chest. In this kind of condition, the person is not able to he won't be able to perform it, so then you will say it's the person is having vestibular impairment. Talking about gait, you need to understand that, see, first you ask him to open his eyes and walk towards a final destination, then you ask him to close his eyes and walk towards a specific destination. If he is swaying towards the right, that means his right side is having a vestibular disorder. Having said that, we have to talk about the degree of nystagmus: first degree, second degree, third degree greater than second degree, greater than first degree. Third degree is also a type of condition in which he'll have nystagmus even when he is focusing on the slow component. Second degree is when he'll have stronger nystagmus than the first degree, but even if he is looking straight ahead. Then first degree is when he has weak nystagmus. Basically there's a weak nystagmus, and when he's looking towards the fast component. Let's talk about the peripheral and central. See, it's very important to understand that in a condition of peripheral nystagmus, the person will have he'll have latency of 2 to 20 seconds, whereas central he have no latency, right? And duration is less than 1 minute in peripheral. In central it's more than 1 minute. Then in peripheral it's usually towards one side. In central it's any side for that matter. So peripheral is fatigable, central is not fatigable. Let's talking about past pointing. Past pointing, we have to remember this mnemonic called as PFS, which means past pointing or falling or slow. When you're talking about past pointing, falling or slow, all of these are towards the slow component. They are opposite to the acute vestibular failure. So let's say a person is having a nystagmus to the left. That means he's had an acute vestibular failure to the right. So his slow component is towards the which side? Towards the right side, where he has had what? He has had the vestibular failure, right? So always remember, if he has acute vestibular failure towards the right, then nystagmus is towards the left, but the past pointing and the falling towards will be towards the cause side. You can remember it. PFS is towards the cause. My bad. It means, see, let's say he has acute vestibular onto the right side, his nystagmus will be the left side, his slow component will be again back to the right side. So it's opposite to the nystagmus side. Talking about Dix-Hallpike maneuver, so this is also called as positional test. See, let's say a person is there, and to detect the peripheral or the central type of lesion, you bend his head. He'll have vertigo in certain position. That is Dix-Hallpike maneuver. What you do first is you turn his head to 45 degrees. Second, you make him lie supine. You keep observing his eyes. And third, you ask, make sure that his head is 30 degrees below the horizontal. Fourth, you shift his head towards the left. Fifth, you leave his head in the hanging position. Now you check for the late, and you again make him sit back. Well, the point is you check for the check for nystagmus. If he has had nystagmus, you check for the latency, the duration, the direction, and the fatigability. So that is very important. In BPPV, which is a classical example of peripheral nystagmus, we see there is a latency of 2 to 20 seconds. It happens within 1 minute. That is the duration, and it happens in one direction. That is towards what? Towards the problem, where the problem is vertigo, inertial position. Right, and it's fatigable in BPPV. But we're talking about central lesions such as tumors in the temporal lobe, multiple sclerosis, cerebellum, fourth ventricle. In all of this, what happens is, you'll have increased intracranial tension. So the nystagmus is produced immediately. This will be a longer duration thing, and it is not fatigable. Let's talk about the test for cerebellar dysfunction. Eye synergia is eye finger nose discoordination. Dysymmetria is unable to control the range of motion. Idiodiokinesia is unable to perform rapid alternating movements. Rebound phenomena is inability to control the movements of extremities when opposing force restraint is suddenly released. Having said all of this, midline base of cerebellum, not very important, just chuck it. Let's talk about laboratory tests. That is very important. So first is very importantly the caloric test. You have 7 laboratory tests, that is caloric test, electronystagmography, optokinetic test, rotation test, galvanic test, posturography and VEMP. So you have posturography, VEMP, galvanic test, rotation test, optokinetics, electro. So when you're talking about the caloric test, so what you need to understand is, let's say you put some water, the person will experience some vertigo, right? What is the basis is, see, it's very simple. You put hot or cold water, you put it for different years, okay? See, here you can test both the ears, both the labyrinths. Second, the point that you can try with hot water and cold water. Then you can compare his experience with the normal vertigo he usually has to say if it is labyrinth induced. First things you have modified Cobra test. Modified Cobra. In modified Cobra test, you ask him to bend his head backwards 60 degrees so that the horizontal semicircular canal becomes vertical. You put ice water of 60 degree of cold temperature for 60 seconds, usually 5 ml. If it is for 5 ml, if he is having nystagmus, you'll have nystagmus which is beating to the opposite side. But even if it's not happening, if you put 5 ml to 40 ml, you continue with more water. Then if it is from 5 ml to 40 ml, then you understand that okay, his labyrinth is hypoactive, but it is greater than 40 ml, you say that okay, it's a dead labyrinth. Then we have something called as Fitzgerald-Halpikes test, also called as bithermal caloric test. I would like to remember it as bithermal caloric test. So in bithermal caloric test, both the temperature water is put. So what happens is you ask the person to raise his head 30 degree forward. Now the horizontal again canal becomes vertical, okay, because its head is moving forward. You give 2 temperatures of water, 7 degrees plus or minus the normal body temperature. One is 30 degrees Celsius, the other one is 40 degrees Celsius. What happens is the person will the cold water will start causing opposite. The cold water will cause opposite nystagmus, whereas warm water will cause same side nystagmus. That is one thing you need to remember. So the cold water will cause opposite side nystagmus, whereas warm water will cause same side nystagmus. So what happens is now the time which is taken from you take all the time, from the time when you started this to the nystagmus occurring and then decreasing, all of that is charted in something called as a calorigram. Right, but if all of this is not responding, like this 30 degree, what you do is you kind of decrease the temperature of the water to 20 degrees Celsius water for 4 minutes. Then you see if that is also not responding, then you declare the labyrinth is dead. Okay, so now depending on the caloric response, we usually determine the canal paresis and dead labyrinth or directional preponderance. Now what is directional preponderance? The nystagmus is more to one direction of the patient. Right, that is what we are trying to get to know. To understand deep of all of things, first things you have something called as canal paresis. What is canal paresis? It is the response to the duration of response in measure of duration of nystagmus, which is elicited from a particular labyrinth. What happens is, how do you calculate this? It is also calculated as percentage. What you do is you take 30 degree ka measurement of left ear, you take 44 degree Celsius का measurement as a duration of time. उसके बाद उसको you so for suppose you're doing it for response for left ear, you take 30 degree Celsius का plus of left ear plus left ear का 44 into 100 divided by left right ear of 30 44 30 44. Likewise for right ear. See, if there is no response from a particular ear, that means you kind of decide that okay, there is some disorder in the vestibular nerve or the vestibular nuclei or the Meniere's disease or something like that. If you're talking about directional preponderance is irrespective of whatever you put water, wherever you put the water, what is the duration of nystagmus? Well, here the formula becomes a little different. For, see, cold water causes opposite, no? So warm water. So for right side 44 plus left side 30 divided by right 30, right 40, for left 30, left 44 into 100. This is going to be the directional preponderance for right here. So you keep right beating nystagmus. Usually the ones who are having like greater 25 to 30% on one side, they'll have a direction preponderance to that side. One dictum you have to remember is that you have to remember, if it is central type of lesion, then the preponderance towards, whereas if it's peripheral, then the preponderance is away. This is one thing you need to remember as a dictum. And canal paresis and this directional preponderance can remain together. See, if canal paresis towards, then you'll have two possibilities. Either canal paresis is to the right, directional preponderance is to the left. That time it is unilateral Meniere's disease. When it is canal paresis and directional preponderance both to the right side, then it is acoustic neuroma. Starting with the podcast series of examinations, we're talking about the trauma to the auricle. Imagine a person like Muhammad Ali or some great rugby player who basically have blood accumulated between like their perichondrium and the auricle. Well, this would be called as the hematoma of the auricle, and their ear would look like a cauliflower or something like a boxer's ear, right? So this is a condition where things might get complicated for an infection, and that might lead to a severe perichondritis. So collection of this blood might lead to infection, right? The way how you're going to treat this problem is, there are two modalities. One is the aspiration technique. You would aspirate it, or you would do an incision drainage. But irrespective of you do any of these two, right? Aspiration will be the first preference. Irrespective of whatever you do, you're going to make sure that you're going to pack it, and the same time you're gonna do some pressure dressing and then do some antibiotics. So you have to pack it, they do some pressure dressing and then do some antibiotics. Talking next about an inflammatory disorder such as a perichondritis, I want you to understand that secondary to an laceration, secondary to a blood collection, or secondary to a surgical incision, or due to diffuse otitis media, or due to furuncle, all these disorders can lead to an infection, of the perichondritis, the perichondrium, right? Usually the organisms which we are really understanding here is pseudomonas, that is the thing, and along with that we can also have other organisms. What basically happens is, this can be divided into three stages. The first stage is where things are red hot and stiff. Second stage is where there is pus between the perichondrium and the cartilage, and then you have the third stage where there is cartilage type of necrosis. Now why is the cartilage necrosis happening is because the perichondrial blood vessels are the only source for nutrition and oxygen supply. So due to decreased blood supply, necrosis can. So three stages mainly. How do you manage this is, you give systemic antibiotics so that there is no infection to the other parts of the body. At the same time, try to curb it down. Second, you do a cold compress of aluminium acetate, which is of 4%. Then thirdly, you do, if it is an abscess, well, anywhere abscess in the body, you should always do an incision drainage or aspiration. So do an incision drainage. Then what you do is, if it is necrosed and if there is a devitalized tissue, you kind of remove the devitalized tissue. Then what you do is, usually some people put a catheter so as to provide antibiotics based on the culture sensitivity of the pus. So that is going to be putting a catheter into it. So as we further go ahead, let's talk about the inflammations of the ear canal, and we talk about otitis externa, and we talk about the infective group. Let's talk about the bacterial part, and especially in the bacterial, let's talk about the localized otitis externa, that is in a specific place, that is furuncle. So let's say you're sitting in the OPD, 10 people come. Out of 10 people, there are 8 people who come with a single lesion, and there are 2 patients who are having multiple lesions. On close examination, you see that these lesions are usually infecting the hair follicle. They're including the hair follicle, and these hair follicles are attached to the cartilaginous part. What you need to kind of understand here is, this infection is typical because these people are complaining about pain out of proportion. So it's a very small nodule, but yet the pain is extremely high. So this kind of leads to your diagnosis of furunculosis, and doing a culture, you get to know it's staphylococcus. So on getting to know that, you understand that this is furunculosis, which is affecting the hair follicle, and this is usually single and sometimes could also be multiple, and manifests as pain which is out of proportion. See, these people will tell you that they have pain even when they're chewing. At the same time, they'll tell that they'll have pain if you're moving the pinna itself. Well, things become more intricate and complicate when you understand that their lymph nodes of the anterior group, the posterior group, and the inferior group are enlarged. Well, what has happened is, within the posterior part of the auditory canal, right, in the posterior part of the auditory canal, this infection has kind of pierced it and gone to the mastoid, right? So it has pierced the posterior meatal wall, gone into the mastoid, caused edema, and it has infected the retroauricular groove of lymph nodes and periauricular group of lymph nodes, right? And the infection has kind of spread. Now, to treat it, you have two things to understand. So if this patient is an acute patient or a recurrent patient, if this person is an acute patient, you have two types. One, if he is having abscess or if he is not having abscess. Well, not having abscess is more beautiful to treat with, because you can give him systemic antibiotics, you can give him painkillers, at the same time give him some local heat, and very importantly, you give him something called as 10% ichthymol glycerine. Well, ichthymol is the compound which has a little bit of antiseptic action, whereas glycerine is the one which kind of decreases the edema, right? So that is important, and decreases the pain, decreases the edema because of the hygroscopic action of the glycerine. But importantly, need to understand this, that if there is any abscess, the best thing to do is incision and drainage. If this person is a recurrent case of furunculosis, you need to understand that this was diabetes mellitus. You have to look for the root cause, which happens to be immunocompromisation, which is because of diabetes mellitus, probably because of old age. So what you do is you look for places where the staphylococcus is harboring itself, right? Vestibule, or you look for other places, fingernails, so that you clean that, you remove it. So here the modality of treatment is more like prevention. Try to remove the underlying etiology. So that should be done. So talking about the diffuse otitis externa, we need to understand that, like when we visit the beaches where the climate is humid, at the same time hot, we need to understand that because of excessive sweating, the acidic nature of the skin, the pH of the meatal skin gets converted to alkaline, because of which the bacteria can easily harbor that place. So what happens is, in diffuse otitis externa, as the name suggests, diffuse, it does not localize to a particular place, it goes to different places, like the epidermal layer of the tympanic membrane, it spreads. Well, additional to that, let's say you have a cut over the meatal skin or near the pinna, or so these kind of conditions will lead to increased infections. Remember all those dumb things which we do after going to the beach. When we come back, we take these, already the skin would be macerated, would be soft, and then you take a stick or you take a pin and then you try to put it into the meatus and then try to scratch it out. Well, the macerated skin will get torn, and then there will be more infections, right? So because of which infections can happen, right? That could be the trauma part. Then talking about common organisms, well, usually we can remember it as E. coli, Staph aureus, or Pseudomonas. You could remember as Coley's, Staph, or pseudo people. The Coley's, cricketer Coley's, Staph, or pseudo people. So these are the common organisms which cause it, but well, that is the external causes. Sometimes, let's say you have a middle ear infection such as a CSOM, and you have been using drops to that, and that will end up, using the drops, and the CSOM itself could, start causing this diffuse type of otitis externa. The clinical features are very varying. Sometimes it's very mild to, something extreme also. Well, you could divide this into two phases. Well, the clinical features in two phases. One is the acute phase and then the chronic phase. In acute phase, there will usually be a reddening, followed by burning, followed by pain, when pain would be there, but if you start mastication or if you use your jaw, the pain will increase. So there will be redness, there will be burning, so signs of erythema basically. There will be thin discharge, right? There will be thin discharge, but this could again become thick, as time progresses. And there would usually be debris. to such an extent that the whole ear gets filled, and because of debris, because of swelling, because of fluid, that it becomes thick, and there'll be conductive hearing loss. Things might get extended to a fact where there would be perforation, and then the lymph node involvement, and that would lead to lymph node enlargement. But when we're talking about chronic, well, the chronic is a little different. You could relate to this, because once you have done with all the pain and all, you'll start having irritation and itching. And here the condition is such that there will be less discharge, but there will be crusts. Everything would be solidified to become crusts. They could be scaling, they could be fissuring, right? But importantly, the meatal stenosis could also lead to hypertrophy, right? The skin could undergo hypertrophy and become extremely thick. When we're talking about the treatment of this condition of diffuse otitis externa, you need to understand that first things first, you have to go to the toilet. Well, we are talking about the ear toilet here. So in the toilet, what happens in the ear toilet, what happens is your main agenda is to remove all the debris, remove all the particles within. You could do it in multiple ways. You could do it with dry mopping, you could do it with suction, you could do it with warm water, which is sterile saline. But mainly you have to make sure that you remove it from the anterior inferior recess of the meatus, where there is more chances of things getting deposited. Well, that is the ear toilet. This happens to be the most single important thing. Well, doing this can kind of change the whole course of the disease. Then talking about medicated wicks, well, you take these wicks, right, after the toilet, after the ear toilet. What you do is you add antibiotic steroid preparations to that, and then you put it inside, and then ask the patient to keep putting drops and let the wick be there only, and let this happen since 2 to 3 days, after which you can change the wick. Well, why we are trying to do this is the steroids will relieve the inflammation. They're going to decrease the erythema, edema, and itching. Whereas antibiotics are going to take care of all the organisms which are there within, right? So antibiotics are going to do that. You can also take up some systemic antibiotics to decrease the penetration, decrease the systemic infection, and analgesics to decrease the pain. Well, this happens to be the treatment for the acute phase. Antibiotics. Before that, you have to take about ear toilet, then medicated wicks. But talking about the chronic phase, what is important to understand is that here the biggest problem is swelling. Decrease the swelling, then you can do enough amount of ear toilets, and you can decrease the itching. So decreasing the meatal swelling becomes the most important agenda. So what you do is you use this something called as 10% ichthyol glycerin. Glycerin again does its anti-edematic action, and ichthymol has a little bit of antiseptic action, and that kind of decreases the swelling, in fact. And so itching has to be stopped. So this will also somehow help the decreased scratching. But importantly, yes, sometimes what happens is that the swelling is to such an extent that you can't change it, and in chronic it is swelling the bigger problem. So what you do is you take a drill and you widen the gap, right, in the bony meatus, right? So, and that part is surgically excised, right? So that happens to be the chronic phase where you kind of treat it that way. So that happens to be diffuse otitis externa.